Hey, A&Pers, this is Dr. Jones checking in. This is A&P 2, Lecture Test 3. We're still working through Chapter 20, The Heart. This should be Video 9, and we should be starting in the middle, bottom of page 15. And where I'm at is impulse conduction through the heart, in case your page numbers are different than mine. So, the functions of the pacemaker cells. Number 1, the SA node makes an action potential and atrial activation begins. Number 2, the P wave, atrial depolarization, and the stimulus spreads across the atrial surface and also through the internodal pathways, and that's this. Number 3, the PR interval, conduction through the AV node and the AV bundle, AV node and AV bundle, and that gives us about 100 millisecond delay. Remember, the mu meant micro, M means milli. And atrial contraction begins. Number 4. The Q wave is the beginning of ventricular depolarization. So the ventricles depolarize, the impulse travels the rest of the conducting system. So that will include the bundle branches and the moderator band. And then 5, you have the QRS complex, which is ventricular depolarization, and you finish atrial depolarization and begin ventricular contraction. So the 2 atria contract, 100 millisecond delay, and then the 2 ventricles contract. Atria contract, 100 millisecond delay, ventricles contract as the atria relax. How is the moderator band involved? And the moderator band contracts the papillary muscles of the right ventricle to prevent the cusps of the tricuspid valve from going backwards. So prevents the Mary Poppins umbrella. Mr. Banks. I was like fully an adult before it finally occurred to me that Mr. Banks worked at a bank. It's almost like his name was his character. Okay. Bradycardia is slow heart rate. Tachycardia is fast heart rate. If the SA node is damaged, the AV node takes over, 40-60 beat per minute. We talked about this in the previous video. If the AV node is also damaged, the Purkinje fibers will still beat at about 20 to 40 beats per minute, which may or may not be enough. So, excuse me. Okay, and an ectopic pacemaker. These are when abnormal pacemaker cells generate action potentials at a faster rate. The problem with the faster heart rate is it doesn't give the heart time to fill, and so you will have a faster heart rate but pump less blood. It decreases the pumping efficiency. Okay, and the EEG, and here are some, okay, that didn't show. Here are some things that you see on pacemakers. Yeah, let's talk about the ECG. These used to be called EKGs. K is for cardio, but in German. C is for cardio, but in English. So EKG, ECG, same diff. The P wave is depolarization of the atria. The QRS complex, QRS, so the Q is down, R is the sharp up, and the S is the little down. The QRS complex is the depolarization of the ventricles and the atrial repolarization. And when the heartbeat is not right and you have an abnormal ECG, you can sometimes see the atrial repolarization separately from the ventricle depolarization. Normally they overlap and show up as a QRS complex. The T wave is repolarization of the ventricles. We are not learning all of the intervals, PR intervals, ST intervals, QT intervals, or the segments, PR segment, QT segment, or QRS complex. No, we're learning that part. But the QT interval has been in the news because hydroxychloroquine, which was oddly suggested as a treatment for COVID-19, increases the QT interval. And not in everyone, but in enough people that it does sometimes cause heart attacks and death. Another QT interval drug, a drug that lengthens the QT interval, is the antibiotic erythromycin, which is a medicine that they're also using in COVID-19 patients. And so the combination of erythromycin and hydroxychloroquine, they're studying, and so far it looks bad. So, and there's always new science coming out. By the time you watch this, things might be completely different. But at the time, I just Googled it to make sure. Right now, it looks like the combination of erythromycin and hydroxychloroquine has the potential to be deadly in a percentage of patients. And we don't know what percentage yet, but enough that they've quit a number of the studies because they're too dangerous. They're doing more harm than good. So, science. We follow the science, not the politics, the science. Okay, that being said, an increased QT interval over a certain amount, I think it's 500, can cause heart attacks, and death. An arrhythmia is an abnormal heartbeat, and that can be an abnormal rhythm or an abnormal force. And then I have a little box here for you to draw out your ECG. As you see, we've got our tiny P wave and little QRS complex in the second box, and then the T wave is in the third box. And the second half of the heartbeat, you're just hanging out. So all of the action is in the first half of the heartbeat at a standard resting heart rate. So we will come back to that. But for now, page 17, cardiac contractions, contractile cells. What were contractile cells again? Cardiocytes that contract. They are 99% of your heart cells, as opposed to the pacemaker cells and the conducting cells. The contractile cells beat because they're muscle cells. Heart muscle cells. 3 types of muscle cells. Quick quiz. Skeletal muscle, cardiac muscle, smooth muscle. And they all have actin and myosin. Cardiac muscle and skeletal muscle have sarcomeres, and that's why they have the striations, the A bands and the I bands, the Z bands. The sarcomeres in the cardiac muscle cell are very similar to the sarcomeres in skeletal muscle cell. Smooth muscle has actin and myosin, but not sarcomeres. It's more of a net, and they morph completely different. The same, but completely different. The resting potential in a ventricular contractile cell is negative 90 millivolts, which is somewhat similar to skeletal muscle. An action potential begins when threshold is reached, of course, And threshold for this set is negative 75 millivolts. And remember, lowercase m, capital V, volt was the dude's name. 3 basic steps in cardiac muscle action potential. Number 1, rapid depolarization. So when you hit threshold, that opens the voltage-gated sodium ion channels. And sodium, and these are fast sodium channels, and sodium, like fools, rush into the cell. Sodium is positive. Positive rushing into the cell makes it rapidly less negative. So rapid depolarization. Now, because these are fast sodium channels, they do close quickly. And this is, I'm trying to show where they close, but I was off. Number 2 is the plateau. You know what they say about plateaus? The highest form of flattery. I can't say it with a straight face yet. I still think it's too funny. Plateaus are the highest form of flattery. 0 days without mom jokes. Excuse me. There's no excuse. It's happening anyway. Okay, because plateaus are flat and they're, but like high, flat, and it's. It's more funny when y'all are like in a room in front of me and you're like, and then I get like one person to laugh and then we laugh. I can laugh at myself though too, so it's okay. If you have any science jokes to add, please include them in the comments. Thanks. Let's keep it clean. Okay, so that was number 1. Number 2 is the plateau. And here is when you open voltage-gated calcium channels. So like neurons, these have voltage-gated calcium channels in the membranes. And they allow extracellular calcium to enter the cell. And at the same time, you close the voltage-gated sodium channels. So you close the voltage-gated sodium channels, open the voltage-gated calcium channels, and the calcium entering the cell is what causes this plateau. And then number 3, you have repolarization, where you close the slow calcium channels, so you stop the calcium entering, and you open the slow potassium channels. So now you have positive ions exiting the cell, and so it gets repolarized back to resting. Notes on the refractory period, it is hugely long. So here's the absolute refractory period where it absolutely cannot start a new action potential, and the relative refractory period where it can, but it's relatively harder. Now, I think we have a picture where we compare that. Okay, so here are the refractory periods in a skeletal muscle cell compared to the refractory periods in a cardiac muscle cell. So the refractory period is very, very, very long. Okay, the role of calcium ions. How many pages have we done? Did I have a timer going this time? I did have a timer going, but I paused it, so that was useless. Let's finish this page. Page 17. So the role of calcium ions in cardiac or skeletal muscle contractions. So in cardiac muscle contractions, there are 2 steps to bringing the calcium ion into the myofibril. Calcium entry during plateau, and this is 20% of our calcium. And number 1 triggers number 2, which is the release of calcium ion from the sarcoplasmic reticulum. So without this 20% extracellular calcium, the heart cannot beat. So this is part of why parathormone is so important. Parathyroid hormone is how they say it now. Is so important because when blood calcium levels drop too low, the heart cannot beat, because without blood calcium, the blood calcium can't trigger the calcium release from the SR, and then you don't do the whole shebang after that, and so no heartbeat. Plus, with low calcium, the skeletal muscle cells will cramp and contract and spaz, and then you have spastic paralysis, which is not good, especially for the diaphragm, which is, of course, the skeletal muscle, as you recall. Okay, and SR, of course, is short for sarcoplasmic reticulum, just so we're clear, which is a modified smooth endoplasmic reticulum, and it stores boatloads, and more boatloads of calcium. Okay. Why is the heart sensitive to blood calcium levels? I just said, because it needs extracellular calcium to contract. And what hormones keep calcium levels up? I already said that too, sorry. Parathyroid hormone. And what hormone makes blood calcium levels go down? Calcitonin, CT. And the energy for cardiac contractions, the heart uses fatty acids and glucose as energy in the presence of oxygen. The heart gets oxygen from the coronary circulation, the left and right coronary arteries, and stores oxygen bound to myoglobin. And this is something we hadn't talked about before. We talked about hemoglobin. Yeah, we talked about hemoglobin and how it has a heme with an iron, and an oxygen binds to the iron in the heme of the hemoglobin. Okay, well, this is myoglobin because it's in the muscles. And it'll be the same thing. There's a heme with an iron and that can bind an oxygen. And so myoglobin is oxygen storage. It's found in the cardiac muscle cell, but it's also found in the skeletal muscle cell, which we largely overlooked last semester. Now you know. And the cardiac cycle is one complete heartbeat. Systole is contraction. Diastole is relaxation. So I can't remember those. So I made my own mnemonic. Systole is when that part of the heart does the squeeze thing. Systole is squeeze, and diastole is don't squeeze. Relaxation. This adventure has been AP2 Lecture Test 3, Video 9, and we did part of 15, all of 16, and all of 17. So we will start Video 10 on page 18. And how many pages do we have left? I have 23 pages in this note set, and then chapter 21 is often but not always extra credit. So check with me on that. Video 10 will be next, and we will start on page 18. All right. Thank you as always for tuning in. The education must go on. Dr. J out. Bye, guys.